Hello, everyone. How are you? It is a lovely day here in Lima, Peru. Very sunny, actually. We're starting getting the summer vibes in the South American continent. So happy to be here today in this 30-minute CP Solvers more virtual morning report with you guys, with my dear Ravi and Charmy. So actually, yesterday we had a quite interesting case that started with a young female presenting with chronic diarrhea and abdominal pain and intermittent fevers. That the fevers during the course of the disease got more frequently, and also in a physical exam, the patient had severe disseminated lymphadenopathy. So we were trying to discuss the differential diagnosis of chronic diarrhea and abdominal pain with fever. And what put us more in our differential were the infectious diseases, but also lymphoma that can present with these fevers, signs of inflammation, and chronic diarrhea, especially in a young patient. We did lymph node pathology and showed granulomas and paracocytomycosis. So my take-home message of the yesterday's case was that tissue is the key. And also in complex cases such as this one, a problem representation helps a lot. So for example, in this case, we were thinking about lymphoma. So we should examine the lymph nodes if we got some clues. And the lymph nodes, a rapid test gave us really the answer. And also some differentials of chronic fever and diarrhea in a patient from South America could include brucellosis, tuberculosis, and also strongyloides. So a great discussion by Kanu and Stefan Saben. I'll pass it back to you, Ravi.
Well, I don't know what to do with this red hot flaming mic that you gave me from all the pearls that you just shared. Thank you. I also would commend you all to check out Kanu's illness script on the website, which Gabrielle shared some additional input on Twitter, and our dear friend Kirtan reviewed, along with our ID guru Kushal, who's also here. Kushal, I have a special surprise for you. And that special surprise is Avale has mentioned earlier that she has a case for us, and she said she's on her ID rotation. So I'm putting 2 and 2 together and tell you that the answer is probably TB, brucella, melioidosis, syphilis, HIV, one of those things. We'll see. All right, Vale, get us going, please.
Great. So this is the case of 54-year-old woman that is from Lima, Peru, and she refers a history of 6 months of chronic cough that had some traces of blood in the sputum and progressed until 1 month before presentation, had an episode of hemoptysis that was half a cup. She denies any weight loss, fever, chills, any other respiratory symptoms really. But 1 month before presenting to our hospital, she went to another hospital and they did an X-ray that was read as abnormal and started on the TB schema, even though she had 2 sputum studies that didn't show any acid-fast bacilli. But anyway, she started on empiric TB treatment, and 2 months after starting TB treatment, there was no improvement, and she was referred to us with this history. I can show you the image if you want, or maybe just stop here before I give you the exam.
Yeah, well, I think an image would be helpful in a second, and I'll just pass the mic to Charmaine to reflect on the dimensions in this case, except the TB, because I'm really reflecting on how hard it is to diagnose tuberculosis. The most common inlet into diagnosing tuberculosis is epidemiology, not clinical syndrome. It's very counterintuitive. TB can cause so many different clinical syndromes that most often it's in our minds only because of base rate and epidemiology. So you could have an abdominal syndrome, a pulmonary syndrome, a brain syndrome, even a rash syndrome, and you should think about TB if it's prevalent in your area. And exactly, Ravi, it's a great mimicker, and so it mimics many things. So often you should really think about it based on prevalence. And how do you diagnose it? Good luck. It's very, very hard to diagnose. And the fundamentals are that you need to see it on PCR and or grow it on culture. However, that's imperfect. So our diagnostic tests for tuberculosis are fundamentally limited, and there's about a 10% rate of presumed TB that was never proven to be TB. And so what's our most definitive tool in our armamentarium if diagnostic treatment is imperfect? It's response to treatment. One of the good things about tuberculosis is if there's no resistance issues, the response to therapy can be very, very predictive. And it's not uncommon in mystery cases that empiric ripe is our treatment of choice. So here, you're saying that there's a cough syndrome in a TB endemic area, and the patient got ripe. I don't think that is a bad thing, unless one of two things is occurring. One, you are not in a TB endemic area, or two, you have a more easily identifiable alternative explanation. So TB is very hard. The diagnostic tests are imperfect. The inlet is prevalence, and the outlet is another reasonable explanation, like lung cancer. So I wouldn't fault this person for empiric ripe. I think it's because it's a TB endemic area. And but there are a lot of things to analyze, like what else is going on. And for that, I'll pass the mic to Charmaine.
Hi, VMR community. It's so good to be back. I've missed you all. And this is already off to a great start. Thank you for reflecting on TB. I feel like there's so much still to learn about TB. Always humbling. So I'm going to just focus on the hemoptysis part of the story for a little bit and tell you how I think about hemoptysis. In terms of hemoptysis, I think that two great mimickers to think about are like epistaxis and like GI tract hematemesis. Let's say like this patient is actually having hemoptysis, and when I think of hemoptysis, I think of abnormal connection between the vessel and the airway, right? Like there is blood going into the airway, and the question is like, where is that blood coming from? Sometimes it's just like irritations, most commonly like bronchitis, bronchiectasis, those things or it can cause irritation over time and cause a small amount of hemoptysis. The ones that you don't want to miss is anyone like post-surgery, any fistula formations that are quite dangerous, and they tend to be massive hemoptysis. And a lot of the times the first step is to kind of think about if this is massive or small, and in this patient, you're kind of worried about more like small volume. So we can just spend some time nerding out. And in terms of like the vessel itself, I kind of think about the structure of the capillaries, arteries, capillaries, and the venous system, and where a pathology might come if it's not more parenchymal, more not irritation and the uritis. And, you know, like heart failure, commonly you get a lot of backup in the venous system can cause hemoptysis. In the capillary world, like a lot of the time they can cause DAH. DAH can do it, and AVMs are a good one to remember as well. And in terms of the arteries, like, you know, pulmonary embolism being the one that we think a lot about, but fistulas are definitely no misdiagnosis. So in this patient, again, like I think we have with the chronic cough and irritation, we're mostly thinking about like airway and parenchymal. However, it's good to also think about like the vessels themselves. I'm excited to hear more.
Great discussion. So in her past medical history, she only had like hypertension, but we really didn't have any other like family history or social history. She didn't smoke, she didn't drink alcohol or use any illicit drugs, and she didn't have an allergy. She was from the north of Peru, but she lived in Lima for the last couple of months because of her course of disease. And so in her vitals, she was a febrile, temperature of 36.5, a heart rate of 80, a blood pressure of 120/70, a respiratory rate of 15, and she was saturating 94% on room air. 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 94% She appeared with no acute distress. The patient was also, I forgot to mention, on antidepressants. She was on, I don't remember exactly the medication, but she was on antidepressants. Because of the disease, she had developed depression because they didn't give her a diagnosis, or she was not improving. It was the most of the exams were normal, except the pulmonary exams, where we noted some bilateral crepitus and also some dullness in the left lower pulmonary side. And also the skin exam was remarkable for a nodule under her left breast. And when we asked her about this, she said that it was itchy, but that it didn't bother her, it was not painful, and that she had this nodule for the last month or so, but before this nodule, she had another one that it was under her right breast, and I was in the left. And so that is kind of the exam thus far. I can give you some imaging, or maybe labs. What do you think? Imaging, right? So this is her. Oh, maybe you can make me co-host, or I can add it in the whiteboard. No problem. Okay. Here it is. You can see it. This was her X-ray on admission. And yeah. What do you think?
All righty. This gets getting more and more fun. I think like just focusing on the background information, nothing there that particularly makes me think she is at risk. You know, she's not particularly immunocompromised, history of hypertension, you know, quite common, and not on any medications. I think this past week on service, a theme has been medication side effect. So another plug to always look at those medications on the side effect. Nothing here that jumps out to me as well. So you know, vitals are vitals. The patient's vitals are quite stable, so we have time to nerd out about this. And maybe I will just kind of think about the nodule a little bit, and then pass the mic to RG for the rest of it. You know, derm is not my strong suit, so every chance I get to kind of like think out loud with you all, I'll take it. You know, especially a nodule that is is not tender, correct? So I think the question is like, is this nodule within the symptomatology of this disease or not? And kind of like think about, you know, your buckets of infectious in general. You know, the thing about nodule that always comes to my mind is like any form of like paniculitis that can present. We often think about it like, you know, anterior shin with erythema nodosum. They tend to be more painful. They tend to be like a deeper nodules, versus if there is any legibility to it or not, like another important characteristics to think about. And with the mild pruritus on top of that, you know, we often think about like, hey, if there's any systemic disease that involve anything with belly that can cause general pruritus, many of the rashes has pruritus, and the fact that it's quite focal is interesting to me. A lot of the infectious rashes that I think about are more generalized than there are that focal. So nothing really is coming to my mind about like helping me pivot with this, but I think is kind of interesting to consider going forward. And I'm curious to see what RG thinks about this.
Charmaine is the kindest soul under the sun when she leaves the lungs for me and takes the dermatology, as with both of us being internists and internal medicine doctors. That is taking one for the team. I really appreciate it. I don't know how to approach the skin thing. And honestly, I would be applying the filter of assuming it's related to the lungs. And so let's talk about the lungs. I think what I see here is a left-sided pleural effusion. And the key question is there also concomitant a parallel pulmonary disease? The left-sided nature of the pleural effusion is very helpful because it essentially confirms it to be an exudate. An isolated left-sided transudate is almost unheard of, but possible. This is in stark contrast to the right side, where you can see an isolated right-sided pleural effusion from heart failure. So this is presumably an exudative effusion, and that's not too shocking since we've had a sort of an inflammatory syndrome in the background. The most common cause of exudative effusions is infection in the whole world. So you have to be open to the possibility of malignancy here, in this non-smoking patient, breast cancer being the most likely. But the spotlight will be on infection. And the question is, what kinds of infections cause this? And the most common causes in the United States are pyogenic bacterial infections, Staph aureus, strep pneumo, and two other ones, the Strep milleri group and Klebsiella. So there's four predominant ones. There's also the sense that there's a lot of anaerobic organisms involved in empyemas that we don't quite culture, the most fancy of which is actinomycosis, which crossed my mind because of the possibility that it might have eroded through the chest wall into the ipsilateral breast, something called empyema necessitans, which you'll also see described with tuberculosis. Apart from pyogenic bacterial infections, which we just talked about, all the granulomatous infections can do it, which are also filtered by epidemiology, with TB being a notorious one. And as we learned from Gabrielle yesterday, paracoxy being another big one to think about in South America. The two other endemic mycoses on my mind in this instance would be histo, which is everywhere in the world, and then sporothrix. So sporothrikosis is a cutaneous disease, but in patients with diabetes and other immunocompromising conditions can disseminate to the lungs. And then, last but not least, the other organisms that can infect the pleural space are parasites. There are three big ones. There's Paragonomycis, Entamoeba histolytica, and Echinococcus. And the latter two are usually on the right side because they tend to involve the liver. So the real focus here in this case is to take a look to make sure this is a pleural effusion and to study it under the microscope. And the microscopic analysis would be very, very informative. As a fun fact, whenever you see skin plus lung in the world of infection, you should panic if you know nothing else, because very sinister diagnoses do that. Things like the plague, things like tularemia, Yersinia, and Kushal's favorite diagnosis under the sun, melioidosis, commonly involve skin and lung. But those are much more hectic and much more lethal than this patient, except tularemia, which should be on our minds here. But it's much more common for a lung disease to disseminate to the skin, and that just revisits our list that we made earlier, except the pyogenic infections. The granulomatous ones in particular are more likely to cause lung and skin. So Vali, you've told us how to make progress. What does this look like with the thoracentesis? And with that, we'll be able to get more and more clarity.
Yeah, so actually there was no thoracentesis done because the patient, well, we have hematology studies first. So the white blood cell count was 10.5 with 25 neutrophils, 25%, 53% eosinophils, and 18% lymphocytes. And hemoglobin was 12. And the platelets were 200,000. Glucose was normal, the bilirubin was normal as well. AST and ALT were 53 and 64 respectively. Yeah, and the alk phos was 93, which is normal. Proteins were 7.6 and albumin was 3.6, and sodium potassium chloride was normal. The urinalysis was also normal, and we repeated sputum studies for acid fast bacilli, which were negative by three times. I love the pearl that you gave about, I don't even know how to say that, emphysema necessitatis. I haven't heard of that, but that's so cool. Yeah, 53% eosinophils. And so, yeah, basically with that, with the eosinophil predominance, I think you can get a smaller differential of what this can be. So what are your thoughts?
Oh my gosh, Valerie, that's so fascinating. Unfortunately, Charmaine's computer crashed. And I will tell you, the whole purpose of Thursday VMR is to do rapid fire thinking. And I think when you say that there's a non-right-sided effusion, a left-sided effusion with eosinophilia in an endemic area, this is Paragonomysis until proven otherwise. Why? Let's go slow down. So you left-sided pleural effusion plus eosinophilia is Paragonomysis until proven otherwise. But let's now go slower. Left-sided effusion is much more likely to be exudative because transudative causes almost always cause right greater than left effusion. So one, this is exudate. Two, what causes exudate? Inflammation, infection, malignancy, autoimmune. Until proven otherwise means that we should focus on it before we move on, and that is infection. So what are the infectious causes of a pleural effusion? We talked about it. Pyogenic infections, granulomatous infections, and parasites. Of them, which cause a significant eosinophilia, there's actually 3 fungal infections to remember. 3. Coccidiomycosis, next to, or paracoccidiomycosis, there's a high rate of eosinophilia in acute paracoxy. And last but not least, aspergillus. The relationship between aspergillus and eosinophilia is complicated and probably represents a subset of people who are atopic to the organism rather than the organism itself. So that's ABPA. So if you're thinking eosinophils, your mind is going to jump to parasites, but you should stop and reflect about the 3 fungi: cocci, paracoxy, and aspergillus. This patient does not have central findings, which are characteristic of aspergillus, things called central bronchiectasis. Patient could have paracoccidiomycosis. Let's put a pin in that. And there's no epidemiology here to suggest cocci. So why not paracoxy? Paracoxy usually causes a systemic syndrome involving the lung. Here, this seems to be very focused on the lung. So moving on to parasites, what parasites can cause an eosinophilic pleural effusion? There are many, but the most common is Paragonomyces. What else could this be? Any of the migratory parasites, Strongyloides, Toxocara, Trichinella, and I bet the list is very long. But what I would do next in this patient is I would talk to her about the possibility of exposure to Paragonomyces, which is usually ingestion of seafood. And if that's positive, and send the serology for it, and go from there.
Yeah, that's brilliant. I actually, just to talk a little bit about that, because the sputum showed X of Paragonomyces, and also a great pearl is that you can make the diagnosis by analyzing the feces of the patient, because you swallow the Paragonomyces because it's in your sputum. So it's an easier study if you have it. And the nodules, which was kind of the mystery of this, is that Paragonomyces actually has a subcutaneous presentation besides the pulmonary, abdominal, and brain clinical presentations that it can have. A great differential, I think, that I thought, because I had seen an schema of several podcasts about eosinophilic encephalitis, was anatostomiasis, which can cause migratory nodules. And this migratory nature of the nodules was actually also very classic of Paragonomyces and with the pulmonary involvement. But I'm so impressed, Ravi. You got it so fast.
Yeah, unfortunately, Paragonomyces' epidemiology is extending, and there's actually now Paragonomyces in the United States. It's a different kind of Paragonomyces. The one that I've heard of in Peru is called Paragonomyces westermani. but we have Paragonomysis kellicoti here in the US. So I've learned about it from unfortunately people having it. And it really is, I think, incredible how I think this case centers around two findings: left-sided pleural effusion, eosinophilia. And that combination should make you think this diagnosis, which is more common than we realize. I really appreciate you highlighting Nathosomyces. I think it's something that I don't know enough about. Do you see it in Peru?
I have never seen a case, but I just thought it was really I know my professors have seen a case because I have asked, but I just know eosinophilic encephalitis and migrating nodules.
Yeah, beautiful. That's really cool. I have to read more about it. That's way more than I know. I have to read a lot about it. Thank you for putting it up. Can you remind me? I think I missed it because I was trying to read from the chat. You were teaching us how to diagnose this best from the sputum and the stool. Can you remind us again?
Yeah. So we can see the infective state, which is the eggs on the sputum, because you eat it basically. So yeah, actually here in Peru, it's very associated with eating crabs. In the north of Peru, there's a lot of seafood, and so it's usually that area that we see a lot of cases, and crabs or seashells. And well, you eat the egg, and so you can see it in the sputum, or as you swallow the egg because it's on your sputum, you can also see it in the stools.
I think Robbie and I are taking turns having computer issues. Sorry, my computer completely crashed. I think you just couldn't handle how amazing this case was.
Well, Vale dropped a fascinating and supposedly rare but not so rare diagnosis on us, which is really, really cool. Vale, this was an incredible case. Thank you so much for presenting it. I learned so much from your analysis. And if the crew wants to put together an illness script on Paragonomyces like we did yesterday, well, we should totally make that happen. I think that'd be really cool. All right, Gabriel, take us home.
What a quite fantastic case, Vale. So for doing the addition points, doing quickly, so we had a 54-year-old female with hemoptysis. So thinking about hemoptysis, this is produced by a Charmin seta and abdominal connection between the parenchyma and the vasculature. So the most common cause of hemoptysis is bronchitis. But for example, in some endemic zones of TB, you should think about this microorganism because it is a fastidious organism that is really hard to diagnose. So later, the patient in the physical exam was quite interesting, the nodules findings, and then with the chest X-ray that showed pleural effusion and eosinophilia. So thinking about that, we started discussing about if this could be a systemic mycosis, sarcoidosis, some bacteria such as nocardia, actinomyces, sometimes pseudomonas that can present with ecthyma gangrenosum and also malignancy. But the clue was the unilateral pleural effusion and eosinophilia. And Ravi told us that it is paragonymous until proven otherwise. Some risk factors for getting this disease includes eating raw seafood, especially in Peru, because eating raw crabs, that is the intermediate host of this parasite. And it can manifest such as hemoptysis, also can have skin manifestation of pleural effusion, eosinophilia, and sometimes it's misdiagnosed with TB. And the diagnosis can be done with microscopic examination of stool or sputum. Thank you so much.
Boom. So incredible. Vale, Gabrielle, you all are amazing. RG, you're amazing. So fun. Can't wait to do this next time. Hopefully next time my computer won't crash. Bye.
Bye, thank you.